Last year, over 2.3 million Americans over the age of 60 went into a hospital for surgery and walked out with a problem they didn't have when they walked in. I want you to sit with that number for a moment. 2.3 million people. Not people who had complications from rare experimental procedures. People who had surgeries their doctors called routine. Surgeries their insurance covered without a single question. Surgeries presented as the obvious, logical next step. My name is Dr. Ryan Mitchell. I've spent the last 15 years practicing medicine with a focus on senior health. Men and women over 60 navigating the most consequential health decisions of their lives. And what I've seen over those 15 years has changed how I counsel every patient who sits across from me. There is a gap, a significant, dangerous gap, between what you are told in a 10-minute surgical consultation and what the published research actually shows about outcomes for people your age. That gap is what I'm going to close today. Stay with me because I'm going to cover 5 surgeries performed every single day in hospitals across America that carry hidden risks most doctors will never mention to patients over 60. I'm going to tell you what the data shows. I'm going to tell you what questions to ask. And I'm going to tell you what I would do if someone in my own family were sitting in that consultation chair. Before I go any further, if you have been told you need surgery, or if someone you love is facing a surgical recommendation right now, type the word waiting in the comments below. I want to see how many of you are facing this decision in real time, because this conversation is for you. Before I get to the list, I need to give you a framework, because without it, what I'm about to say won't fully land. I want you to think of your body as a battery. When you're in your 30s, that battery is fully charged. You can work late, catch a virus, push through a hard week, and your body absorbs every bit of it. The reserve is enormous. In your mid-60s, through no fault of your own, through nothing you did wrong, that battery has naturally settled, perhaps to 65 or 70% capacity. And here's the crucial thing I need you to hear clearly. 65% is completely fine for daily life. You walk, you cook, you travel, you feel well. Daily life draws on that battery at a rate it handles comfortably. But a major surgical procedure, general anesthesia, significant incisions, the trauma of healing, infection risk, the metabolic demands of recovery. That is not a daily draw on your battery. That is plugging an industrial appliance into a household outlet. This concept has a medical name, frailty. And frailty is one of the most misunderstood words in medicine because it has nothing to do with how healthy you look or how active you feel. Researchers at Johns Hopkins, studying over 500 elderly surgical patients, found that frailty, your body's biological reserve, predicted post-operative complications and whether patients ended up requiring long-term care far more accurately than their chronological age. The number on your driver's license tells you almost nothing. The reserve in your body tells you everything. And here is what connects every surgery on the list you're about to hear. The procedures themselves are not always the problem. The problem is the combination of reduced biological reserve, insufficient pre-surgical preparation, and alternatives that are never presented in the consultation room. Now let me walk you through them. We are going from concerning to genuinely dangerous. Surgery number 5. Arthroscopic knee surgery for osteoarthritis. Here is what this procedure promises. A surgeon makes small incisions, inserts a camera and instruments into your knee joint, removes damaged cartilage, smooths rough surfaces. Minimally invasive. Logical. Your knee hurts, so remove the problem, right? I want to tell you about Margaret. 71 years old, retired school principal from Charlotte, North Carolina. Chronic knee pain that was limiting her morning walks and making trips to the grocery store uncomfortable. Her orthopedic surgeon showed her the imaging, pointed to the cartilage damage, and told her this procedure would give her her life back. 6 months after surgery, Margaret called my office. Her knee wasn't better. In her own words, "It feels like I went through all of that and ended up exactly where I started. Except now I have a scar, and 6 weeks I can't get back. Margaret's experience is not an outlier. A landmark study published in the New England Journal of Medicine followed over 350 patients with osteoarthritis who received arthroscopic knee surgery. 2 years later, patients who had the surgery reported the same pain levels as patients who received only physical therapy. The same. And in 22% of cases, patients reported their knee felt worse after surgery than before. Because the surgery creates additional trauma to an already compromised joint, it forces scar tissue formation, it exposes you to anesthesia, and for osteoarthritis, a condition caused by the progressive breakdown of the joint, not by loose fragments, cleaning up cartilage does not address the underlying disease. What does work? A combination of targeted physical therapy, anti-inflammatory nutrition, glucosamine and chondroitin supplementation, and low-impact movement has been shown to reduce knee pain by up to 38% within 3 months. No incisions, no anesthesia, no recovery period, no complications. Surgery number 4, spinal fusion for chronic lower back pain. This is a major operation. Surgeons permanently join 2 or more vertebrae using metal rods, screws, and bone grafts. The logic is straightforward. Stop movement between painful vertebrae. Stop the pain. Think about the last time your back hurt. Not a sharp, dramatic injury, just that familiar ache that made standing up from a chair uncomfortable, or made a long car ride something to dread. You may have taken something for it, waited it out, and assumed it would pass. Most of us have handled back pain this way most of our lives, and most of the time, that patience works. But for some people, after years of this cycle, a surgeon shows them imaging that looks alarming and offers a permanent solution. And the word permanent sounds like relief. Here is what the permanent solution actually delivers for many patients over 60. A major study published in the journal Spine found that in patients over 65, complex spinal fusion had a complication rate exceeding 40%. Not minor complications, blood clots, infections, hardware failure, and something called adjacent segment disease, where the vertebrae above and below the fusion begin breaking down because the mechanics of the spine have been permanently altered. The hardware holds one section rigid, and the vertebrae next to it pay the price. A 2019 study compared patients over 60 with chronic lower back pain. Half received spinal fusion, half received intensive physical therapy, core strengthening, and targeted pain management. After 2 years, both groups reported similar pain levels, but the physical therapy group maintained dramatically better mobility, experienced 0 surgical complications, and saved an average of $87,000 in medical costs. If what you're hearing is valuable, and I believe it is, do something right now that takes less than 3 seconds. Hit the like button. And if you are not subscribed to this channel yet, subscribe. I release information like this every single week, and I promise you, it is the kind of information that can change a decision, and that decision can change a life. Hit subscribe now. I'll wait. Surgery number 3. This one makes me genuinely angry, and I want to explain why. Cholecystectomy, gallbladder removal, is one of the most performed surgeries in America. Over 600,000 per year. And here is the pattern I see repeatedly. A senior patient has a routine ultrasound or CT scan for an unrelated reason. The radiologist notes gallstones. The patient is referred to a surgeon. The surgeon recommends removal. The patient, who has never had a single symptom from those gallstones, agrees because their doctor told them to. Your gallbladder has a function. It stores and concentrates bile, which helps you absorb fats, and critically, the fat-soluble vitamins your body depends on, vitamins A, D, E, and K. Remove it, and your body loses that concentrated delivery system permanently. Research published in Frontiers in Aging found that up to 40% of people over 60 develop gallstones at some point in their lives. Here is the number that changes everything. Only about 20% of people with gallstones ever develop symptoms. That means 80% of people with gallstones, 80%, will go through their entire lives with those stones causing zero problems. If you remove your gallbladder simply because stones appeared on a scan, you have an 80% chance you have just removed a functioning organ for no medical reason. And the consequences? Research from 2021 found that 47% of patients who had their gallbladder removed experienced chronic digestive issues afterward: diarrhea triggered by fatty meals, bloating, difficulty absorbing nutrients. For seniors, malabsorption of fat-soluble vitamins can accelerate bone density loss, muscle decline, and cognitive impairment over time. If you have gallstones but no symptoms, no pain, no inflammation, no fever, the question to ask your doctor is not, when should we schedule this? The question is, why should we remove a functioning organ that is causing me no problems? Surgery number 2. And this is where I need you to pay the closest attention, because this surgery is the most serious on the list, and the misunderstanding around it is the most dangerous. Coronary artery bypass grafting, open heart surgery. They stop your heart. They connect you to a machine that breathes and pumps for you. They graft vessels from other parts of your body to reroute blood around blocked arteries. For seniors in active cardiac crisis, unstable angina, a heart attack in progress, heart function deteriorating rapidly, this surgery can be life-saving. I am not arguing against cardiac surgery in those circumstances. I am talking about a different population entirely: seniors with stable angina, chest discomfort that is predictable, managed with medication, not escalating, not causing heart function to decline. For this population, a landmark study called the Courage trial, published in the New England Journal of Medicine, followed over 2,000 patients with stable coronary artery disease. Half received bypass surgery or stenting, half received optimal medical therapy, the right medications, supervised exercise, dietary modification, stress management. After 5 years, there was no difference in death rates or heart attack rates between the two groups. None. Invasive surgery provided zero survival benefit compared to medication and lifestyle modification for patients with stable disease. And the recovery from open heart surgery is brutal. Studies show that up to 50% of patients over 70 experience significant cognitive decline following the procedure: confusion, memory gaps, and personality changes, likely due to time spent on the heart-lung bypass machine. Some recover, many do not fully. If you have been told you need bypass surgery, the question I want you to ask is this: is my angina stable or unstable? If the answer is stable, you have time. Time for a second opinion. Time to try an optimized medical program. Time to ask whether an aggressive medication and lifestyle protocol has been genuinely and fully pursued before anyone opens your chest. Before I get to number 1, which is the surgery that concerns me most, the one over 450,000 Americans have every year, I want to ask you something. Think about one person in your life over 60 who has been told they need surgery. A parent, a friend, a neighbor. Are they watching this with you? If not, pause this video right now and send it to them. Copy the link, text it, share it to your Facebook page. You might be sharing something that fundamentally changes the decision they make next week. I mean that. Please share this now, then come back. Surgery number 1, total hip replacement for moderate arthritis. The one I think about most. Over 450,000 Americans receive total hip replacement surgery every year, and the majority are over 60. The marketing is compelling, the before and after stories are dramatic, and for some patients, In specific, carefully evaluated circumstances, it genuinely transforms quality of life. I want to be clear about that. But here is what the glossy consultation brochure does not tell you. A total hip replacement is exactly what it sounds like. The ball of your hip joint is sawed off. The socket is reamed out. A metal stem is hammered into your femur bone. A metal or ceramic ball is attached. Your hip socket is lined with plastic or ceramic. You now have a completely artificial joint, and that artificial joint has a lifespan. Modern hip replacements last an average of 15 to 20 years. For someone who has the surgery at 65, that means revision surgery, removing the old implant and installing a new one at 80 or 85. Revision surgery in patients over 80 carries a documented complication rate of 28%. That includes infection, dislocation, fracture, blood clots, and death. 28%. But here is what concerns me most about who is actually receiving these surgeries. The vast majority of seniors who get hip replacements have moderate arthritis pain, not severe disability. They are still walking, still functioning. They have real discomfort, yes, but they have not exhausted the conservative options that the data shows can provide meaningful, lasting relief. I want to tell you about a patient I'll call David, 73 years old, former marathon runner from Houston. Hip arthritis was limiting his morning walks and making his golf game painful. His orthopedic surgeon showed him x-rays and said, "You have the hip of someone 20 years older. You need a new one." David came to me before signing the consent form. I asked him one question. Are there things you love that you absolutely cannot do anymore, or are they harder than they used to be? He thought about it. Harder. Much harder, but not impossible. We built a program together. Daily glucosamine and chondroitin for cartilage support. Curcumin with black pepper for inflammation. A targeted hip strengthening protocol 3 times a week. Swimming and cycling instead of running. Acupuncture for pain management. Twice weekly anti-inflammatory nutrition coaching. 12 weeks later, David came back. He had played 18 holes the previous Saturday. He wasn't running marathons, but he was there, on the course, playing the game he loved, with his natural hip. "I almost let them take something I can never get back," he told me, and I never once heard that I had another option. A study published in Nutrients found that a combination of glucosamine, chondroitin, and collagen supplementation reduced hip pain by an average of 43% within 12 weeks in patients with moderate osteoarthritis. Another study in the Journal of Clinical Nutrition found that seniors who combined daily low-impact exercise with omega-3 supplementation experienced pain reduction equivalent to non-steroidal anti-inflammatory drugs, without the gastrointestinal risks. Your natural hip has a range of motion that no artificial joint can replicate. Once the surgery is done, you cannot cross your legs. You cannot squat fully. You have movement restrictions for the rest of your life. That is not a small trade-off. That is an irreversible intervention when reversible options have not been fully explored. So here is where we are. 5 surgeries. A combined total of millions of procedures performed every year on Americans over 60. And behind each one, a conversation that is not happening in consultation rooms. A conversation about alternatives, about long-term outcomes, about what the research actually shows for people your age. I want to give you something concrete to walk away with. Before any elective surgery, write these questions down right now. The 5 questions Dr. Ryan Mitchell says you must ask. 1. What happens to my condition if I do nothing for the next 6 months? 2. Have we fully exhausted every conservative option? Physical therapy, medication management, lifestyle modification, targeted supplementation. 3. What is your personal complication rate for this procedure in patients over 65? 4. Is there a minimally invasive or catheter-based alternative to this procedure? 5. Will this surgery extend my life or only change my symptoms? And what does the data show for patients with my exact profile? A surgeon who is offended by these questions is giving you information. A surgeon who answers them thoroughly and honestly is the surgeon you want. And if you are facing a planned surgery in the coming weeks or months, ask one more question that most patients never think to ask. What can I do between now and the surgery date to arrive in the best possible biological condition? That concept, prehabilitation, strengthening your body before a planned procedure, has been shown in published research to reduce post-operative complications, shorten recovery time, and improve long-term outcomes. Push for it. It is one of the most powerful tools available to you, and most patients never hear about it. The operating room is not the enemy. Surgery saves lives every single day, and I have watched it do extraordinary things. But surgery is a massive physiological event, and in a body where reserve is limited, the margin for error narrows. You deserve to know that. You deserve to walk into every consultation with the questions that open a conversation your surgeon might not have started. The colonoscopy you've been postponing, the second opinion you've been meaning to get, the symptom you've been quietly normalizing, the supplement protocol you've been wondering about. These are not small things. They are the decisions that determine which version of the story you live. You are not a passive recipient of medical decisions. You are an active participant in your own health. And the moment you walk into a surgeon's office, you have every right to ask hard questions, demand real answers, and take every day you need. I want to hear from you. Which surgery on this list surprised you most? Or, and this is the one I really want to know, have you or someone you love already been through one of these procedures? Share your experience in the comments. I read every single one, and I want to hear your story. If this video gave you something useful, a question to ask, a conversation to start, a decision to reconsider, please do 3 things right now. Like this video, subscribe to this channel because I release content like this every week designed for adults over 60 who want real information, not reassurance. And share this with someone who needs to see it. One share from you might start a conversation that genuinely changes someone's life. Aging is not a weakness. Your body's capacity to recover and adapt is remarkable when it is given the right support and the right information. You deserve both. I'm Dr. Ryan Mitchell. Take care of yourselves and take care of each other.